inviting me. It's been very interesting watching all these videos. As always, I learned new techniques which I didn't know before. So let me run through 10 nailing. Basically, it's mostly used for fracture shaft of femur in children. Can also be used in other instances. I'll try and touch upon it, but I'll stick to femur mostly. So I'll just straight away go on to the treatment. I think we don't need to do anything else. Ages 4 to 6 becomes a gray area. You can do early spica casting, you can do traction spica casting, you can do submuscular plating, you can do flexible intramedullary nails. I'll come to that. But the TENS is primarily used in this age group. In the 6 to 11-year age group, in fracture shaft femur, we have, what do we have in the armamentarium? We have TENS, we have submuscular plating, we have external fixation. But what has become the gold standard now is the TENS nail. I don't think there's any doubt. All over the world, everyone uses this. And this is something even a general orthopedic surgeon should know how to do well. So what is TENS, otherwise known as SN, elastic stable intramedullary nailing? You have, this is the armamentarium that you need. You have nails from 2 mm to 4 mm at with 0.5 millimeter increasing gradation. The tips are always curved. It's mostly blunt. You have some makers which have a sharper tip, and you got to be a little wary about the ones with a sharp tip. You need to have a slightly blunter tip. And then you have an awl, you have the curved awl, you have the straight awl, you have the chuck, the insertion ram, etc. I never use the ram. I'll just come to that. I just use the chuck. And in the chuck, you have a short end and a long end. So basically that gives you the orient. You can put the tip of the nail, which direction it's facing accordingly to the chuck, either to the long end or the short end, so that as you're going in, you know where the tip is facing. Either the tip is facing lateral or medial, and you don't have to keep shooting to see where the tip is. And you can turn the nail accordingly. And then you have this extractor inserter. This is the breaking tool, and this is the impactor, the F tool, and this is the most important one, which is called the F tool, which is used in for your close reduction. Principles, I think all of us know this. It gives flexural stability, it gives translational stability. So it's a very stable fixation. There's no doubt about it. And it's been borne out by many studies over the years. Titanium versus stainless steel. Why not use stainless steel? Steel is stiffer than titanium. So titanium nails are more flexible than steel. There's better biomechanical stability in torsion and axial compression. There's better gap closure. We can achieve good compression and a decreased nail slippage. But there have been reports on stainless steels where you have good, better clinical outcomes than with titanium. So, but the world has moved on to titanium. Ender's nail, all those in Gujarat, some in Maharashtra, I know Premal is here. This in fact is a case of Premal's. I have no experience in this, but they have a lot of experience in Ender's nail, which is stainless steel. It's a 7-year-old close. He's done the superb nailing, and you can see that it all heals well and with an excellent clinical result. So this also can be done, and I'm not saying that titanium nailing is the only answer for fracture shaft femur. Advantages, why do we do them? Short hospital stay, early mobilization, avoid complications like shortening, angulation, avoid hassles of POP care. There are limiting factors which we have to know. Limiting factors are 11 years of age and 49 kgs in body weight. It's a little bit stretchable here and there, but this is a general rule that children over the age of 11 and those who weigh over 50 kgs, you can't nail them. Principles are very important. You need pre-bend nails of equal diameter. You cannot put unequal diameter nails as they will cause varus or valgus. At the fracture site, you have to have a good pre-op assessment of the nail size. You have to put in the largest nails that can be passed into the femur. I think that's fairly straightforward. They have to occupy 80% of the canal at its narrowest diameter. So the diameter, if you measure, say, 5 mm at the narrowest, you multiply it by 0.4, and your size of the nail will be 2 mm. That's just an example. No femur that you're going to nail is going to take a 2 mm nail. So you're going to have 8 mm, 9 mm, sometimes even 10 mm, where you have to use a 4 mm nail. You need a normal size radiograph. Remember, we're living in an era of digital X-rays. All the X-rays are compressed. So either you ask for a normal size radiograph or you find out what is the compression factor and apply that to your calculation. So that's very important. You need a fluoroscopy table. That of course is obvious, or a fracture table. You have to have, you can either do retrograde or antegrade incision. All of us do retrograde. Entry points should be mediolaterally at the same level. That's also equally important. So that's how it is. at the same level, and you need to be away from the distal femoral physis, at least an inch away. Okay, so that you protect the physis. Bending the nail is important. You have to give a good convexity, maximally at the fracture site. Remember, you use a tool to bend. Use a bender, French rod bender. Do not bend with your hands, as you'll create a multiplanar bend of the nail and not a uniplanar bend. Technique, entry point, use an awl, you drill it, use an awl, nail insertion. I'll come to all that. Advance the nail till the fracture site. Do not cross the fracture site with the first nail. Then the second nail is inserted, also brought to the fracture site. Both nails are at the fracture site. And then advance one nail. The initial, what we all learned was try and advance the tougher nail first. But I think that doesn't make sense. Insert whichever nail you can to reduce the fracture. Once you got it across to a reasonable extent, insert the second nail and then get a good spread of the nails at the fracture site. So this is what I said. Your bending, contouring has to be maximally at the fracture site so that you get maximum convexity at the fracture site. So your lateral nail should go all the way to the trochanteric apophysis. The medial nail usually goes a little bit into the neck. Then you cut the nails short, as I'll show that. So you cut the nails, impact them in. I have a video. Let's see if it plays. So this was a case I did years ago in Ganga Hospital. The child had a fracture shaft femur. That was a fracture shaft, simple, straightforward. They stabilized it with an X-fix. And I went in to remove the X-fix and nail it. So that's the fracture. I used this entry point
Vijay,
where the distal shank screw was, because there's no point putting another entry point.
Vijay, we can only see
I'll just move
slides,
forward.
Video.
So this was the armamentarium that you should have all of this on the table. You should have a full set of nails. You have this French rod bender, and then you have the chuck here, which I said with the long handle, short handle, and then the impactors, and a full set of nailing, the ram, etc., which I never use, but it's there. Those are the nails.
Vijay, we can't seem to see your video, Vijay.
And that's the bender which I'm going to use. I'll show you that later. That's a simple French rod bender.
Vijay, stop. Vijay.
Run this through. That's the impactor that you use at the end. That's the impactor.
I don't think he can hear us. Finally.
So once you've prepped this thing, we make a very small. I use a regular fluoroscopy table. I don't use a fracture table, and I'll come to that. The first step is in templating the nail. So I keep the nail over the femur and I identify the fracture site. I know where my lateral nail is going to be. That's where it's going to end roughly. So I put a corkers there, like that. Sorry, yeah. Identify where the nail is going to, where the maximum convexity is for both the lateral nail. And then I do the same for the medial nail. I know where my nail is going to end. And I also put a corker at that point because the nail will be slightly to bend at different places. Once I do that, I use the French rod bender to create the maximum convexity at that point. Remember, always use the French rod bender. Make sure that the nail is not bending in different planes while you're bending it. That's very important. So that's how the nail is bent. And then both nails are pre-bent. You don't do this afterwards. I like doing it well before I start the surgery so that I'm absolutely ready with it. Once I'm done with that, we go on to the exposure. We make, all of us do this. We make a small incision on the lateral side, cut the vastus a little bit, go in, and then put in the awl. So we make an awl, make it fairly large. If you're using a 3 mm nail, I at least make a 3.5 to 4 mm opening. Use the awl to enlarge it so that my nail goes in easily. And then the same thing is done on the medial side. Now with the medial side, I do a small, I take the medial nail and I always bend the tip a little bit more on the medial, for the medial nail, because I find that it bounces off the lateral cortex far easier if the tip is bent a little bit more than what it is on the lateral side. So I bend the tip of the medial nail a little bit more than what I do on the, what is there already. So that is one thing I've learned. That is easier once you bend the tip on the middle of the medial nail a little bit more, it bounces off the lateral cortex easier. Then insert the lateral nail. I tend to insert the lateral one first, just because it's just makes more sense to me. If I'm on the lateral side, advance it till the fracture site and stop. And then the middle nail is inserted. You can have your assistant do it, or you can do it yourself if you're alone. Again, the middle nail is progressed up till the fracture site. And then we go about reducing the fracture. So in fresh fractures, it's very easy to reduce. It's not tough. Just give traction. You can use the F tool. You can use the bump under the thigh to get the fractures in alignment. We pass one nail, whichever is easier, it goes in, and that will stabilize the fracture. You push it into a fair bed and then go on with the second nail. So just this, I'm particularly showing this because once you put in the first nail, it's not always the second nail is going to go in automatically. So you may have to again re-reduce, manipulate a little bit, and then get the second nail in. Yeah, so once you get the second nail in, you progress it up the canal and make sure that the lateral nail ends close to the trochanteric apophysis. You don't want to pierce the trochanteric apophysis. And what I do with the middle nail is I like going up into the neck for all cases wherever the fracture is, just because there are proximal fractures where I nail, there are cysts where I use nails, and I need the nail up the neck. So it is just a practice for me. You do a frog lateral, look at the neck, make sure that you're well inside the neck and go up as far as possible. And this is where the fracture was. And you can see that the spread is maximal at the fracture site in the AP view. And the same, you can see that I'm pointing to that. You can see the spread of the nails at the fracture site, the maximum convexity is there. And even in the lateral, there is a good spread at the fracture site. So this is what is essential. You don't want what is called a corkscrewing of the two nails where it twists on itself and you have no spread at the fracture site. And that is where the nails end up proximally. And that's just coming to the cutting. So once you've inserted the nails, and then I tap them in the end. So that's me just tapping the nail in. And I like leaving the nails short. I leave them against the bone like that. I leave them short because I don't remove these implants. Now the world is divided between those who remove the TENS nails and those who don't. There's enough literature on leaving them in. There's enough literature on pulling them out either. I don't remove them personally. So we'll go to some examples. This is a 4-year-old. You can see that the shortening was quite a bit, more than 2 centimeters. The child was chubby. I was not sure I could do get away with just a spica. And so I decided to nail, and you can see again, same principles. You have to have good spread. The nails go in long enough. 6 weeks post-op, 18 months post-op, there's no real problem. This is another 6-year-old. Again, this is an indicated case, absolutely indicated. You can see the spread of the nails at the fracture site 2 months later. This is a 4-year-old child with a proximal shaft. Now, this is where you got to learn how to get the nail in long enough. So this is again a close reduction. And you can see that the lateral nail has gone into the trochanter. The middle nail has gone up the neck with good spread of the nail at the fracture site. So your bending has to be according. You just don't bend the nail and the middle of the nail. You template it where the fracture is and bend it there. 3 months post-op, it all heals well. 8-year-old male, again, similar. Now, and you can see they all go on to heal well with a good result. What are the complications? This is not a perfect system. You have to know where the problems lie. You can have loss of reduction and what are called linked unstable fractures. This is courtesy Dr. K. Wilkins, who taught us all, basically taught us pediatric trauma over the years. So this is the post-op case, and this is what happens 1 week later. There's a huge fragment there, like a butterfly fragment, and that will collapse. What he taught us was to put in simple X-fix for a few weeks and then remove it. Just 1 pin proximally, 1 pin distally. That will go on to heal well. Now, this is a 7-year-old boy. This was the case. I think I had a wrong X-ray. It measured 5 mm. Anyway, I tried putting in bigger nails. I ended up pushing this fragment away proximally. It became a length unstable. So what I did is I just added 2 mm KYs with a just distractor on the side, kept it for 3 weeks, and that went on to heal well. That's the final result. And I do it simply on a fluoroscopy table because I can check rotations of the hip, rotations of the femur and the alignment much easier than I would on a fracture table. There is a 3-nail concept, but that hasn't really taken good hold. This was a child which was done by a colleague of mine. You can see what happens. He ultimately managed only to put on 1 nail. He put a spica. This is not ideal at all, but because the child is a child, this is 6 weeks post-op, and that goes on to sort of remodel. Okay, so but this is not ideal. When you do it, you got to learn how to do it properly. You can have missed lateral injuries. This is a child I nailed. This is 8 years old child. I had a hematoma. I aspirated the knee. We couldn't find any real injury on the X-rays, but there was a hematoma with flat globules. I should have warned the parents. Anyway, I went ahead and nailed the child, and then came back with a bar and a flexion deformity of the knee. There was a posterior bar, and that had to be reconstructed later on. So you can have malrotation. So that's why I do it on a regular table where I check it always after nailing. Irritation from the nail ends, you know, to remove it. And sometimes you can get a procurvatum deformity. Tibia also can be nailed similarly. My indications for nailing tibia are rare and few. I don't nail them usually. I treat them conservatively, but it's the same principles, same spread of the nails, exactly the same. And in forearm fractures, again, my indications for nailing forearms are not very frequent, except when there are floating elbows. The same thing. What is important in the forearm fractures is you got to maintain the intra space. So your contouring has to be to that. Humerus too can be nailed similarly. That's the follow-up where everything heals well. In conclusion, this is not flexible intramedially is effective, relatively economical method of fixing femoral fractures in the 4 to 6 years, and definitely in the 6 to 11-year age group. And in the older children, you don't do this. You do rigid lateral entry dock nails. External fixators and submuscular plating are still useful in the if you're using hands. Thank you very much.
Thank you, Vijay. That was a